Well, for more on maternal mortality and what's being done to address the issue, I spoke with Dr. Barbara Levy. She's the Vice President for Health Policy at the Advocacy Division of the American Congress of Obstetricians and Gynecologists. She began by explaining why the U.S. has such high rates compared to other industrialized countries.
Some of it is access to care. Some of it is the increasing age of moms in this country. A lot of it is underlying illnesses. It's obesity, it is diabetes, high blood pressure, and some of it is that we are a little bit complacent. We expect delivery to be a wonderful thing, and so our awareness is not where it should be for those little signs and symptoms that, if caught early, would help us.
Now, in terms of the countries that are doing a good job when it comes to how they take care of mothers, what are some examples of countries that are doing this well, and what lessons could perhaps the U.S. learn from them?
So Great Britain, the Scandinavian countries, a lot of it is access, that there's universal coverage for people, but a lot of it is also systems. It's consistency, it's measuring outcomes. So we can't fix what we don't understand, and if we're not chronicling the morbidity and mortality, if we're not keeping track of it, then we're not looking for the problems. So in this country, it's a state-by-state issue about whether we're keeping track of maternal mortality, and not all states have maternal mortality reviews. The countries that do it well track that very carefully and intervene quickly when they're starting to see something that's not right.
So what are some of the policies and the resources in place in the U.S. that are really addressing this issue?
I don't think that doctors coming down and saying this is how you need to do it, or women advocating for ourselves, are going to be that successful. We have to all gather together. And so we have a program called AIM. It's the Alliance for Innovation in Maternal Care, that is bringing together state public health organizations and providers and women and nurses and midwives, everybody sitting around a table and looking state by state to see what the issues are, because the issues here in DC are going to be different than they are in rural Georgia or in Alaska.
Now, one issue that does seem to come up is this issue of the rate of C-sections. And we know that the World Health Organization says that in the US, the rate of C-sections is too high. Now, obviously, we know it can save a life, but it is surgery. There can be complications. What do you think is the correlation between C-sections and maternity mortality or morbidity rates?
There's not a direct correlation with the first C-section, but for a third or a fourth or a fifth C-section, that the placenta, which is the organ that supplies nutrition to the baby, can find its way in the uterus to a scarred location, and that can lead to a lot of bleeding with birth, and can be very severe bleeding to the point where even a hysterectomy has to be done, or moms can get into big trouble. So it's really the second and the third and the fourth and the fifth C-section that's an issue. And in this country, very frankly, part of the issue is fear of a bad outcome. So in general, we don't get sued for doing a C-section too soon, but we certainly see bad outcomes and say, well, if I had just done a C-section earlier, something might have been better. And so it's a difference in culture in many ways, but it's also the liability that the hospital and the physician and the family really take on.
Now, I do want to ask you something that we saw in a 2015 study about the difference between midwife, physician, laborist practices, and they said that they tend to have a lower number of C-sections versus some of the private practice models. And we know that some of these hospital physicians are paid per procedure as opposed to salary. You would hate to think that there's a business angle to this. What's your assessment on that?
Well, there are a couple of things that confound that data. One of which is that large hospitals can afford to hire and salary hospitalists and midwives and doulas, whereas rural or smaller facilities rely on private practice. So that's part of the issue. The actual physician payment difference between a vaginal birth and a cesarean birth is $30, $40. I mean, I don't know the exact amount, but it's so little that it wouldn't drive behavior. What drives behavior is the resources. You know, a woman in labor needs support.
Right.
And a laboring woman who's been laboring for a long time wants it over. And so if a private practice physician who has 20 patients waiting in the office stops by labor and delivery and she's saying, I want it over, the likelihood is a cesarean delivery will happen. If you've got employed people who are there full time in the hospital supporting that patient in labor and giving her alternatives and options, it tends to drive a lower cesarean rate, but it's about resources. And so it's really not a fair comparison because the larger hospitals with more births and more resources tend to have the employed physicians and the hospitalists and the midwives.
Now, ideally, if you did have a magic wand, if there was a place that you could start when it comes to really improving some of these outcomes, where do you think would be a good place?
So I think there are two things that we really want to focus on. One is measuring the outcomes. It's looking at mortality, morbidity reviews, and systematically collecting that data and being able to respond to it. And the second is a culture change. It is to say that every single woman in America needs health coverage. And she needs coverage before she becomes pregnant, because some of these things need to be addressed before we get pregnant. And then, of course, good care during pregnancy. And that's a systems issue. It's not choosing the right provider. It's having a system that's supportive for women.